And now to help us understand a little more about how the ACA has impacted premiums and how the individual market has changed since 2014, we're pleased to have Loren Adler, Associate Director of the Center for Health Policy, the Brookings Institution, to share his research with us today. Loren?
Hi, thank you very much, and thank you, Erica, for that great presentation as well. I think right now, I think obviously the attention is understandably and rightfully so focused on the large premium increases coming for 2017, especially with the big news earlier this week reported by HHS and ASPE about the 22% increase in premiums for the benchmark plan. And yes, obviously the increases vary widely across the country, and subsidies are protecting a lot of these people from those increases, and many people can choose new plans, again, as Erica was walking through. But I also want to take a step back here to put the ACA's premiums in perspective, even for the rest of the unsubsidized population. As you can see here, this slide now looks slightly out of date now that we have some data on 2017, especially from the HHS data now, but I think this has been a very talked about point, but the fact that premiums came in significantly below, 15 to 20% below what the Congressional Budget Office, Congress's neutral scorekeeper, group of economists basically, thought premiums would come in originally is certainly part of the story for why we are seeing such large premium increases for 2017. There was certainly an element of underpricing initially, and an additional data point in that ASPE analysis was that we are actually now for 2017 premiums in the ACA on average nationally are going to be pretty much exactly in line with where the Congressional Budget Office predicted they would be in 2017, which honestly is for all the flack CBO takes a lot of the time, some are and some not. It's a pretty remarkable feat to do that. I don't know, maybe some of the should have assigned some of the CBO economists to the co-op plans maybe. But I think we are seeing some of that, and that just gives you some context of how premiums started. And I think even more than that, this next slide right here shows this is also taken from Congressional Budget Office data that me and my colleague Paul Ginsberg basically extrapolated and analyzed from looking at premiums in the non-group market for comparable plans before the ACA, showing that premiums in the ACA actually also appeared low in 2014 and 2015 compared to non-group comparable plans in the non-group market before the ACA. Again, that's an important thing to note when you're talking about these big premium increases coming this year. Again, basically unwinding the low premiums we saw originally. I think we just walk through, and obviously I think that finding seems jarring at first glance because there's obviously a number of elements in which the Affordable Care Act pushes up premiums in the individual market. Obviously, the guaranteed issue being a big one, that you have to sell insurance at everyone, and that you can't turn away people when they're sick or stop insurance when people get sick. Obviously, there's certain minimum benefits you have to provide, essential health benefits and such. You have to have out-of-pocket limits on your health insurance, and you can't have lifetime limits on the benefits you provide. But on the flip side, there are also a number of elements of downward pressure on premiums that the ACA did provide into this market. A big one, on which the McKinsey presentation focused on a lot, is the pretty large rise of narrow network plans and managed care offerings inside the individual market now, and their data had shown that basically the premiums in these narrow network plans are generally about 20% lower than their broad network counterparts, obviously having a big role in that, at least back, not to 2017, so back in 2016. Plenty of anecdotal evidence that provider reimbursement in ACA plans has been lower than in the rest of the commercial market. And then also just simply by creating a transparent marketplace where, at least from survey data, we have seen that the consumers, ACA consumers, seem to be very price sensitive, which should drive down premiums on the whole. I just want to caveat some of this sort of prospective data, just that the Congressional Budget Office data is a little bit older on the non-group market data from before the ACA, obviously. And a big part of this is when looking at pre-2014 data, there is a very big difference between the mean and the median premiums. So a big part of this is there were sick people who still were getting insurance before the ACA. They were just paying very, very high premiums for that in many cases, or in some cases in high-risk pools even. But there were people paying $10,000 a year and such for premiums. So from all of the data sources I've seen, the median premium is often 60, 70% of what the mean would be nationally, which is why all of the reports of people, healthy people who were buying insurance in the market beforehand really did see these large premium increases when the ACA took off, and the people who continued buying coverage in the individual market. So I don't want to imply that those people didn't see those premium increases, and that's part of the reason. It's just that the people who saw really high premiums before saw very large decreases. So on average, they sort of even out in that sense. But that's they're looking at very broad averages, sometimes disguises a lot of individual circumstances. Again, the reinsurance component also that lowered premiums in 2014 by anywhere from 10 to 17% I've seen estimates of, and still was keeping premiums down by 6% or so this past year. And again, obviously, premiums just differ very widely across the country. So it's sort of unfair to, these national comparisons sometimes are a little bit unfair to make in some points. I think the real point of making this is just to say that the ACA in some ways has just not solved all of the problems of health insurance. It's not that the ACA is somehow magically cheaper, which I think a lot of cheerleaders of the ACA hoped that it could be miraculously cheaper than other modes of delivering care, and that seems to be moving back more in line with other forms of delivering insurance, which kind of gets me to my next slide, which there was an Urban Institute analysis recently which showed a very similar finding, basically highlighting, it was sort of in line with what we had done, highlighting that in 2016 ACA premiums, when adjusted to be of similar actuarial value, effectively, especially just moving forward to 2017, effectively are basically equivalent to employer plan premiums. They found that they were 10% lower, but with the premium increases coming this coming year, the ACA premiums are going to be roughly the same as employer premiums across the country, although from this map you can see that they again vary pretty widely and where things are different. But in some of the times it's explained. So you're seeing, for instance, in 2017, the ACA, you are seeing big premium increases coming in New Mexico and Pennsylvania, for instance. However, those states also had very low premiums relative to ESI premiums in those states. So in some ways, it's not surprising that you're seeing that happen in those states. In a similar way that some of the big premium increases were coming in states that had just very low premiums relative to national averages to begin with. Just to say that I think some of this is coming from just trends coming back towards the mean, and things just sort of coming back to normal as we're gaining experience and people are learning more about what's going on. All of this really is to say that healthcare is crazy expensive in the U.S., but that didn't magically start with the Affordable Care Act. When we spend 20% of our economy on healthcare, doctors make very healthy salaries. Hospitals often exert near monopoly power. It shouldn't be a surprise that unsubsidized ACA premiums are also proving expensive for so many. And that's really the key point I want to make here. Many of the problems attributed to the ACA are really broader in nature, and therefore require us as policymakers and the folks in D.C. to look at controlling healthcare costs more broadly than just pigeonholing specifically to the ACA. And that doesn't mean that the ACA doesn't need improvement. It certainly does, especially in certain markets where we really do need a higher ratio of healthy people to sign up. But I think it's also important to put the news of ACA premiums in their proper context so that we can focus on solving the key problems out there and fix what what really needs to be fixed. And thank you.